Dear colleagues, the next speaker doesn't need any introduction. Professor Neuhaus is one of the most highly skilled interventional endoscopists, and his outstanding live demonstrations are well known all over the world. I can only mention now some of his achievements. He is the past president of the ESGE. Recently, he got the International Service Award from the ASGE, and he established one of the most successful international workshops, the Düsseldorf Live Symposium. At this symposium, the first ESD in Europe was performed, and the list goes on. And one of his special focus and passion is the pancreaticobiliary system, and he will talk now on current and future role of cholangiopancreatoscopy. Please.
Thank you very much, Stefan, for this very kind introduction. Jan, it's a pleasure for me to be here and to participate in this outstanding conference. I would like to talk on CPS, cholangiopancreatoscopy. These are my disclosures. So we have three different methods for DPS: direct peroral cholangioscopy, or DPOCS, mother and baby cholangiopancreatoscopy, MBCP, and single operator cholangioscopy, or cholangiopancreatoscopy. The term single operator is a little bit misleading because DPOCS is also a single operator technique. So this is done with a pediatric gastroscope, for example, the Olympus GRF H180N or the XP 290N. Single operator, reusable. This device has a 4.5 millimeter distal diameter of the distal end. It provides, in contrast to the other technology, high-def image and image-enhanced endoscopy, for example, with the new AVIS X1 technology, TXI and NBI, four-way deflection, a large depth of field from 3 to 100 millimeters, and it has a 2.2 millimeter working shell, which is so far not available from any other instrument for cholangioscopy. The challenge for DPOCS is the biliary access, because we have to overcome the angle between the duodenum and the CBD. And as these images show, either you advance the scope and it's more proceeding into the deeper part of the duodenum, or loop forms in the gastric stomach. But it can be done. Otherwise, the alternative is a guide wire or a balloon anchored approach. As shown here, a balloon is inflated in the right hepatic duct, and then by pushing and pulling, we can advance the periatic gastroscope into the CBD. And as you can see, we get excellent image here with NBI. This is the hilum. Obviously, the balloon catheter is in the right hepatic duct. The challenge is when the instrument is not in a stable position and you remove the balloon, then there is a potential risk that it slips back towards the papilla. So this patient had a distal indeterminate biliary stricture, which is now here evaluated now with NBI. And as I said, we can use forceps as we do for pediatric gastroscopy. The MBCP is a two operators approach, the mother and baby scope, reusable instruments, and the mother scope is a conventional therapeutic duodenoscope, whereas the baby scope is a latest generation, the CHF B290, providing an imaged enhanced endoscopy, TXI, NBI, two-way deflection, a large depth of field from 1.5 to 20 millimeters, and it provides a 1.3 millimeter working channel. So this is an example here in a patient with a hilar stenosis. We've just seen the cystic duct junction. We're approaching the hilum, and as you can see, we get an excellent image with the option of a detailed evaluation of the mucosal structure and switching to NBI also of the vascular structure. And here, this was a hilum. We can precisely define the interluminal spread of the tumor. We can exclude skipping lesions coming back here to the cystic duct junction. SOCP is provided with instruments either SpyGlassTM, well established, and recently eyeMAX was introduced, not yet available in Europe, but I had the opportunity to use it in patients in North America. It's quite expressive. Single operator approach, disposable instruments, in contrast to what I've said before. But we don't have an image-enhanced endoscopy, four-way deflection. We don't know the depth of field, no information from the company. And the inner channel diameter for SpyGlass, 1.3 millimeters, and for eyeMAX with a 9 French, there's two different devices. 9 French is 1.2 millimeter, and for the 11 French device, 2.0 millimeters. And the advantage is that they have a dedicated irrigation and aspiration connections. So coming to the indications, one of the most important diagnostic indications is the elevation of indeterminate biliary strictures, IDBS. And the aims of cholangioscopy are to visualize the lesion and to characterize endoscopically. Tissue acquisition under direct visual control, delineation of intraductal lesion margins, and evaluation of skipping lesions. The challenge is how to characterize ductal changes. There are different classification systems. I cannot go into the details. This is one of the most recently published for SpyDS, the MENDOZA classification. You can see here the different parameters suggesting malignancy, and this multi-center trial finally showed an overall diagnostic accuracy of 77%. So quite impressive, and in any way far better than what is shown with fluoroscopy. An example here in a patient with PSC, we are just past the confluence. There is an indeterminate stricture in the anterior lobe on the right liver. And as you can see, a very tiny stenosis. And these should be evaluated before any manipulation, as shown here. Another advantage of cholangioscopy is that we can proceed to targeted cannulation. So it would be impossible to pass this stricture just with ESCP techniques. In addition, we can here proceed to fragmentations of intrahepatic stones proximal to the stricture. And as you have seen, after dilatation, it's very difficult to characterize. But we have, of course, the advantage that we can take biopsies under direct visual control. Now, how effective is SOCP in combination with tissue acquisition for IDBS? A systematic review and a meta-analysis was done on studies with the digital system in a period of approximately 5 years, and they included only those studies with a control arm with histopathology of the surgical specimen, autopsy, or long-term clinical follow-up, and only studies that enrolled more than 10 cases. And in total, 11 studies were analyzed, and these involved 356 patients diagnosed through biopsies. And the results show, so for histological evaluation, for malignancy sensitivity of 0.74. This is by far better compared with any trial on ESCP with brush cytology or biopsies taken under fluoroscopic control. Specificity very high, so we rarely see false positive results, 0.98. Of course, you can argue these are uncontrolled series, maybe biased, and in many of these trials, we don't see an intention to treat analysis. And we were the first in our group who did a randomized control trial together with centers in Hyderabad and in Hong Kong on comparing SOC with ESCP alone. A small study, but the results showed superiority of SOC sensitivity of visualization, 96% compared to 67% if you do just ESCP. and the overall accuracy was also significantly higher, and the sensitivity for tissue acquisition, 68%, whereas ESCP with brushing showed only a sensitivity of 21%. Quite disappointing, but this was a prospective randomized controlled trial. So clear advantage for cholangioscopy. How about DPOCS? There is a new classification just published in GI endoscopy from Korea, the BUCHEAR classification, a retrospective single center study. So this may be a limitation, retrospective, but they enrolled 471 patients, 131 had neoplasm, and the technical success rate of DPOCS was 97%, so extremely experienced group, and of those who underwent biopsy tissue acquisition, 95%. And this is what our Asian colleagues like, a very, very detailed classification. I cannot show explain the different criteria, but they characterize the structure and the vascularization. And as you can see, when we have irregular vessels, then we have an odds ratio of more than 50, so 50-fold higher probability that this lesion is malignant. And if we combine surface structure and microvascular pattern, then they reported on a sensitivity of 87%, specificity 82%, and accuracy rate of 84%. And these are just examples of their publication. On the left, you see this granular pattern of the surface. And if you would use just white light, as with SOC, then it's probably not very likely that you would judge on malignancy, but in combination with NBI, you see the irregular vascular pattern, and finally they took biopsies, and this is an adenocarcinoma. Now, cholangioscopy, as I've mentioned, can be also used for preoperative evaluation of the resection margins of the intraductal spread of the tumor for exclusion of skipping lesions. This is more and more preferred now by HPB surgeons. And this study, a couple of years ago, was done in 118 patients with a presumed diagnosis either of CCA or IPMN of the pancreas, or biliary of the biliary duct. And cholangioscopy finally changed the surgical plan in about 1/3 of the patient, either by less intensive or more extensive. So this is a clear also advantage. So for therapeutic indications, here you see an impacted stone. So many of us know how much time we sometimes spend with mechanical lithotripsy, and this is very easy to insert here a baby scope. We have the excellent image under continuous irrigation. This takes 10 minutes to fragment the stone. We can follow the fragments, and we already see now a lot of smaller fragments which can be easily removed with a basket or with a balloon catheter. So many studies on cholangioscopy-guided lithotripsy. This is one of the largest series published by Amit Maidero, 17 centers in Asia, 156 patients, and as we can see, the stones were usually impacted, and ductal clearance was obtained in 80% in a single session. So very effective techniques for difficult stones. And we can also use SOC and also the mother and baby scope technology for evaluation of pancreatic lesions and also for lithotripsy of pancreatic stones in chronic pancreatitis. The challenge is when we have an association with strictures, then it's difficult to approach stones. However, our group with Christian Gerges and Thorsten Beiner recently reported on 40 patients, a prospective multi-center cohort trial. Technical success, it means intention to treat analysis with fragmentation and clearance of the PD in 90%. And as you can see, this is also followed by clinical success. drop of the IDBS pain score, and pain relief completely or partial, and adverse events are not higher compared to standard interventions in chronic pancreatitis. Further indications, radiation-free removal of bile duct stones. We can use baskets with these devices without any radiation. Removal of migrated endoprotheses on foreign bodies. All of you know how time-consuming sometimes to catch migrated endoprotheses under fluoroscopy. Resection or ablation of intraductal lesions, and percutaneous transhepatic interventions for failures of POCS. And this is just an example of a patient with previous left hemipatectomy, metastasis at the hilum. We already succeeded to drain segment 6 and 7 with percutaneous drains, but you see then segment 5 completely blocked. No chance to overcome this complete blockage with radiological techniques or with ESCP. And what we can do in these cases, we inject here contrast. You see no flow of contrast into the CBD. We advance a sheath over the wire. A 12 French sheath is enough. And then we insert a SpyDiscover, so a shorter 65 centimeter long cholangioscope. And we can nicely identify the radicals here and advance a wire under direct visual control in this very angulated stricture, and then in combination with fluoroscopy, you see the angulation here. The wire is now in the CBD, and then we can follow with dilatation, and finally we place 3 metal stents. So I would like to conclude. Current role of CPS undoubtedly the evaluation of indeterminate ductal lesions and treatment of bile duct stones not amenable to ESCP. In the future, we will see more and more requests also for surgeons for mapping of intraductal tumor extension, targeted cannulation of difficult strictures, especially at the hilum. We know how much time we sometimes spend with fluoroscopy. Extraction of migrated protheses, foreign bodies, radiation-free interventions, and replacement of mechanical lithotripsy and ISVEL for biliopancreatic stones. All CPS methods that I showed are effective and safe. The choice depends on local expertise and indications, and we can expect a rapid technological improvement, especially in terms of imaging quality and image-enhanced endoscopy, as I've already shown, implementation of AI, larger accessory channels, and improved and novel accessories. And my prediction is that CPS will increasingly replace fluoroscopy for biliopancreatic interventions. So this is a fantastic conference here, but when you cannot wait for the next one, then I strongly, together with Thorsten Beiner, my successor in Düsseldorf, recommend to come in February to Düsseldorf. Thank you very much. Of course, Stefan is also our faculty member.
Thank you, Horst, for this outstanding presentation, these fantastic videos. Jan has a question, please.
So more and more we are talking about green endoscopy, and the single-use, single-operator cholangioscopy has several advantages, but the disadvantage is that, as you said, the classifications with NBI are not possible. If you start to introduce NBI in SOC, maybe it will be even more cost expensive. In which direction are we going? Will we be able to have a mother-baby system that is not so fragile, or what do you think?
It has already been improved a lot. So the 290 is already a step forward, and now it can be also used with a new AVIS X1 platform. But the durability, of course, depends also on the individual expertise. So there is no doubt that the learning curve is shorter for the disposable instruments. But as I said, when you have enough experience, also DPOCS is still an option. But I think compared to disposable duodenoscopes, this is a smaller amount of waste because we don't have so many cases now for cholangioscopy. And we wait for recycling technologies.
But I think we have to be honest, when I saw your videos from the disposable instruments, I think with regard to the white light, they are almost comparable with the others, or is this incorrect? So,
the image quality?
Yes, image quality from the white light.
It's probably enough for most of the cases, no? But hopefully I showed. So as you said, I have commitments for Boston Scientific, for Microtech, as well for Olympus. So I'm not biased. But I didn't say this is the best image. Therefore, I showed the videos, and all of you got your own impressions. But I agree. When we see the progress on smartphones, then we can expect, even with the smallest CMOS chips, further improvements. Yeah?
Okay, thank you very much, Horst, for this outstanding presentation, and we come to the next.